Thank you for joining me to talk about a protocol that we've developed at BrainLinks for concussion, and we'll talk about a lot of resources. My name is Wendy Elmo, and I am a speech language pathologist, and I've worked in brain injury for much of my career. Let me first tell you about who we are at BrainLinks. We are supported at the federal level by a grant from the ACL and at the state level by the Tennessee Department of Health Traumatic Brain Injury Program. And we're a statewide group of brain injury specialists. And what we do is give professionals in a variety of different fields all of the information, the training, the educational handouts that they need to better serve people with brain injuries across Tennessee. And all of our materials are very family friendly. They're written at the lowest educational level that they possibly could be. They are for return to school, return to work, all kinds of different things. You'll see a lot of them today. And we have toolkits, one for healthcare providers. You'll see some of that today. For school nurses, for survivors and families, that would be another useful one for you. And for other service professionals, like people who work in home or their case management or work in the community with people with brain injury. We have a YouTube training channel where you are viewing this. And we have a new program called Tennessee Brighter Futures, which has lots of great resources. We'll talk a little bit more about that. So we'll talk about this concussion management protocol that we've developed, how we got to it, what it is, what it looks like, what it's asking for you to do. We'll talk about screening for a prior history of brain injury. We'll go through some of the toolkit, and then I'll talk about Tennessee Brighter Futures, which is kind of a related, but not directly, but a really important program for you to know about for more resources. So you'll probably hear me say concussion more than MTBI or mild traumatic brain injury. The convention pretty much has been concussion, and now the pediatric guideline is saying let's switch it to mild traumatic brain injury. And I think that's to focus on the fact that it is a mild traumatic brain injury. I kind of go back and forth, so that's what you'll hear from me today. So how we work at BrainLinks, we do lots of coordination with other groups. We talk about what they do. For instance, like a domestic violence group, we go to them and we learn about what they do, what they know about brain injury, what they have in terms of resources to provide to their folks with brain injury. And then we also figure out what do they need developed. We develop trainings that are suited for them specifically. We get a lot of calls from people out in the community who are kind of trying to cope with their brain injury. So we get to hear a lot about what the issues are for folks in the community. And we do a lot of talks and a lot of trainings as the bulk of what we do. And all of that leads to lots of research. We dig in to find out, well, what is known about, for instance, domestic violence and brain injury? What is known, what isn't known? And then we develop lots of those new materials, like I said. And from all of that came a lot of the tools that we've developed, but also this concussion management protocol that we're going to talk about today came very much from the research and from what is happening in the field and what is happening with folks. So we found out from talking with the people with concussion or possible concussion that they don't always go to their healthcare provider for a diagnosis. They are not always seen for a second appointment because some aren't asked to return, and then some don't follow the recommendation to return. And then they're often not given a symptom-specific referral. They're not given educational material. They're not monitored over time for that concussion, and they're not screened for prior history of brain injury. Now, this is by all means not across the board. This is not everybody. This is just what we will hear from some folks. When we talk with healthcare providers, what they've told us about is there's a lot of variability in terms of treatment, in terms of when they see people back. If they do see people back, some people are seen within days, they're referred someplace else, maybe to a specialty provider. Some are seen back in the office within a week, within 2 weeks, within 4 weeks. Some people just come back when they feel like they need it. So there's lots of variability in terms of that. There's variability with regard to educational materials that are provided. And this is, I'm not saying that any of this is bad. This is just what it is. There's variability in where people tend to refer. Who do they just go to a neurologist kind of as that first stop, or they go to symptom specific? What do they do with regard to referrals? And then there's variability also in terms of screening for prior history. Often there's not a lot of time that you're seeing folks. So often that's something that's not done. So Nathan is an example of somebody that we hear about all the time. So he's not a specific person. He's kind of a group of people. So we'll go out and we'll give a talk, and we'll have typically a mom come up to us at the end and say, you were talking about my child. At 10 months, they fell down a flight of stairs. They were crying. There was no loss of consciousness. They went to the hospital, but they said that there was no concussion. There were no recommendations given, and there was bruising around the right eye for weeks. At age 24 now, so many years later, so clearly this is someone who was injured years ago, and a lot has changed since then, but we're still finding people like this as well. They're currently in prison. They're an addict. They've tried everything. They can't or maybe won't hold down a job. It's hard to say. They are very smart, but they've struggled in school. They have few friends. Maybe they have borderline personality disorder. And we say, this is great. I'm glad that you've identified this. There are things that you can do. There are accommodations that can help. There are people that can help. And usually at this point, the mom says they won't get help. This is just who they are, and they won't get help. Other examples, JJ, he had a concussion during football practice. He was sent to his primary care provider and diagnosed with a concussion. The return to play was gradual. He realized he was having some trouble academically, and he was given a few informal adjustments for 6 weeks. He was impulsive and had a low frustration tolerance. So a lot of the right things were done here. Still, 6 months later, we look and we see he's getting into fights. He's having some residual issues. He was arrested over the weekend for buying drugs, and he's just to try to make his head feel normal. We hear that a lot, that sometimes they'll try different things because they're trying to make their head feel normal. Gina had a concussion 2 years ago. She says, they tell me I'm fine. I can't work. I tried. I can barely do all that I need to organize the house, the food, and my son's life, his school and his sports schedule. She has to rest after doing just a few things and says, sometimes I'm wiped out for the rest of the day. I'm overwhelmed. I need help. This is pretty typical. Some of the research shows, and there's a lot of research coming out now looking at when you were injured young and what happens in later years. And what we see that when the mild traumatic brain injury occurs in preschool, then about a decade later, we see more ADD, conduct disorder, oppositional defiance, substance use disorder, mood disorder. And then when we jump ahead that decade, when they're injured at, say, 16, and then we jump ahead 5 to 10 years, we see that they're abusing substances, that they're committing violent and property offenses. So it used to be thought that, well, a concussion really doesn't last. A concussion doesn't cause long-term issues. And they can create problems in somebody's life, even a decade or more later. With the adult literature, there's a study or two that look 30 years out, and that the troubles that people are having, and that's not just mild traumatic brain injury, though. So here is the concussion management protocol that we developed because of all of these things that we were seeing in the community, in the literature. And what we're doing is asking healthcare providers to see people for a minimum of 2 visits when there is a concussion, bring them back again because people are sitting out there in the community. We'll go through this much more specifically at 4 weeks. By 4 weeks, bring them back, and then yearly checkups. Let's go through some of this. So the initial visit, there is an ACE. Now you can use some sort of evaluation. One that's recommended by the CDC is the ACE, the acute concussion evaluation. It is quick to administer. It has good psychometric support, and it is recommended by the CDC. And there's an example of it right there. It looks like it's a lot, but if you haven't used it, but it's very quick to use. A lot of it is kind of explanation. And there is an emergency department. So this is the in-office one. In 2023, there are new, if you're used to using the SCAT, there are new SCAT tools for different ages, and the SCOAT, the child and the adult and adolescent version. So those are available as well, also quick to use. On that initial visit, you also want to use an age-appropriate symptom scale. That's one of the recommendations from the CDC, from the pediatric guidelines. The unfortunate truth, though, is that there is not an age-appropriate symptom scale for all ages. We do include in our toolkit, which I'll talk about later, ones for child, teen, and adult, one for the parent to use in office if it's a child, and then one for the parent or the adult patient to take home so that they can continue thinking about symptoms and can come back to you. They kind of better see the reason to come back to you within 4 weeks. So, like I said, there isn't one for 5 and under. They do exist for the older ages. And again, we recommend that you send one home so that they can continue to look at things, because people don't know what concussion symptoms are. They won't necessarily realize that because I seem to be thinking more slowly, or not even realize that they are thinking more slowly until they see it there and say, oh, okay, yeah, I am having some difficulty. Also, at that initial visit, we recommend that you give the ACE care plan. There's a return to school or work version. If you look over at the left-hand side, you'll see it's highlighted. That's the school version. There's a work version as well. And that comes from the idea that we need to be providing patients with instructions on their return to activity customized to their symptoms. And if you use this, research shows that you will have increased patient follow-up, increased recall of, and adherence to discharge recommendations. So that ACE care plan can be really important. It's also recommended that you send information to school or to work, not that you send it directly to work, but that you give it to the patient and they can choose to give it to their employer or not. And this is the CDC's letter. Now, I know that many people have developed their own, and that's great. So if you want, you can compare it with this, just makes it nice and easy, or you can continue to use your own. But it's that idea that it's important to be sending something like this home. And so it's communication with the school. You're sharing symptoms, your approval to return to school or an excuse from school, and accommodations. And the school will have a sense of the accommodations that might be helpful, even though the school doesn't have to use those. And if you share the recommendations, the adjustments, the accommodations, it does make it more likely that they will be implemented. And then we need to coordinate this care across systems, really, to help people to get the services that they need where they need it. We want to be providing patient education at that first visit, because you might not see them. They might not come back. If you give them the educational materials, including that, but not limited to, that symptom scale that you're going to send home with them, that can help them to understand the need to come back. Many clinicians and the public still don't realize that concussions are treatable. So if you have symptoms, you don't have to wait for them to go away. They may or may not, and you don't have to just sit and suffer with them either. And people who receive education show better outcomes. People feel that they need more education about their concussion, and education that helps the transition should be provided, any transition that they're going back to. This is the tool. It's actually a group of tools, but they're by age group, that we recommend that you use. So this is when concussion symptoms aren't going away. And we're suggesting giving this at that first visit so that they understand what that symptoms may not go away. They may. You want to let them know. Most people, they are absolutely going to go away, typically within 4 weeks. We'll talk about that. But here's some information to look at should they not go away, and please come back if they don't go away. So 5 and under talks about what you're going to look for in a young child. It talks about engaging with the early intervention system in Tennessee, and we'll talk about the age range in Tennessee that's served by TES has just changed. We'll talk about that in a minute. So you might just need to help let people know about that as well, and what applies to them. When the school-aged one goes through, again, what are you looking for, but then also how do you engage with the school system? If you have a neurotypical child, you don't really know how, or a typically developing child, you don't know how, sometimes even that the special education system exists in your school, but then how to engage with it and what how to best advocate for your child. And then the last one, the blue one, dark blue one, is for adults and adolescents, teenagers. And this is returning to college and returning to work. So first visit. Now this is a recommended first visit, but doesn't have to be. Our brain health document is also evidence-based. It's great to give out with concussion because you want them doing everything they can to maximize that brain, but really it's good for anybody. And then this concussion in mental health, you can give that out at the first time, or you can wait and give it out the second time. But wherever it's appropriate, again, knowing that they may not come back, they may not even realize that the fact that they're kind of feeling depressed has anything to do with their concussion. So we'll leave that to your discernment. There's also a symptom tracker, which is good to send home if there are maybe a really troubling symptom, or maybe like there's a headache, and this helps the patient to give how severe is that symptom on a 1 to 10 scale, what was happening to when that symptom came about, what did you do about it, what did you try, and then what happened, and what's the outcome of that intensity level. And they should bring this back to you, and that can give you some information about do I need to intervene here? Do we need to give a medication? Do we need to send off to somebody? Or do they seem to kind of be handling this? And we want to really just encourage them to continue using the strategies that they are. That can give you a lot of information and help people to learn their own triggers as well. When I seem to be in this environment, this is difficult for me. So you can give out signs and symptoms tools. We have those as well. And everything, I believe, that is ours from BrainLinks is available in Spanish as well. And they are in the toolkit, the Spanish tools. So you can hand this out, but if you've already diagnosed it, kind of there's no need. You can hand it out, though, for the future. So what are they going to be looking for if this child ever, or this adult ever, hits their head again? Also, it can be helpful if, let's say, they had a fall 6 months ago, they never came into you, you don't know if they've had a concussion, they don't know, you can give this and you can say, did you have any of these symptoms? Look this over. That can give you some indication of whether they had a concussion at that time or not, or prior history. The purpley one in the upper right is for people who communicate without words. So if you have a patient who has maybe a developmental issue and they communicate without words and they've fallen, how can their family help to understand if they have had a concussion or not? So the current recommendations concerning rest are that it's 2 to 3 days of rest only, and they should increase their activity as they're able to, as long as it's not increasing symptoms too dramatically, and longer rest is actually shown to prolong symptoms. There is no benefit to prolonged rest, and in fact, it may cause problems. So we want to kind of make sure that we're all up to date on that current recommendation regarding rest. So we are resting for those first couple of days, and then it's our emphasis there that's a safe exercise, because so this means like a stationary bicycle, a treadmill. It could mean a walk in the neighborhood, but maybe somebody with you, because we hear all the time of somebody who was re-injured very soon after that first injury while they're still recovering, where maybe they these are all true stories where someone stepped off a a stage, didn't go down the stairs, stepped off the stage, because you're not really fully processing everything. Someone else going to the gym and then walking not through the open glass door, but walking up into the glass panel that was next to that door. Going back to work, to your high school job, and dropping the big pasta boiling pot on your head as you're trying to get it down from the shelf. All things that we've heard. So we have to keep people safe during this time where they're not fully processing. So mild, safe exercise is recommended as long as there's only a mild increase in symptoms. It is okay, and it is probably helpful. So a lot of studies on that now, that if we have activity-based interventions, they can improve concussion symptoms. Obviously, athletes need to be removed from play. If they have a sports-related concussion, they should immediately be removed, and but they should not eliminate all physical activity and cognitive activity. Just like everybody else, they should still stay involved with things, but not necessarily their sport. We're removing them from play. So in the concussion management protocol, we're saying return at most by 4 weeks. So you don't have to wait for the 4 weeks, but and some people, like I said, there's a lot of variability. Some people bring people back very quickly to work on their symptoms. So why 4 weeks? We use that as the cutoff because there is a lot of variability among individuals when their symptoms clear, but most symptoms will go away within 4 weeks. So if you wanted to wait it out, as long as the symptom wasn't severe and causing a lot of distress, you could wait till then and then say, come on in, or you could bring them in earlier. So current findings suggest that recovery is kind of domain specific. Some seem to clear quicker than others. There can be some modifying factors like gender, may depend on what tool is being used to measure recovery. Different tools are showing different things. So you may use one tool that looks like they're recovered, but they're not quite. May depend on what population is being looked at, as some populations recover earlier. New neuroimaging studies, though, do suggest, though, that recovery may be even longer. So when some of our tools that are not neuroimaging suggest that that they don't have symptoms anymore, the neuroimaging suggests that it could be actually a little bit longer. And I believe also that the biomarker evidence is showing a little bit longer than what people say they think they're done. So what we see in this kind of 4-week issue, what we see as current practice is a lot of variability. Elite athletes sometimes begin specialized treatment within 3 to 7 days post-injury, to being seen 1 to 2 weeks, to being seen at 4 weeks, to not seen again. There's no recommendation to return. So this is just to give you an idea of what seems to be currently the current practice. So you can see where you fit in with that. The recommendations say that rehab services should be provided early if you're going to be doing that. So if we return people by at most 4 weeks, that allows for an earlier referral to services if needed. And then at that I'll call it the 4-week or that follow-up visit. If symptoms persist, or if there are new behaviors, then consider a symptom-specific specialist. So that could be everything from a specialized concussion treatment center. We have one here in Middle Tennessee. It could be a brain trauma center. Those are scattered across the state. Sports medicine, neurology. So neurology, often headache is a good referral to the neurologist. What we hear, and this is going to be some people, not across the state with everybody, is that some neurologists won't take what they're calling just a concussion. They're too busy and they're treating other things. And then sometimes it can be very difficult to get into. So everybody doesn't have to go to the neurologist. Maybe it's a neuro-ophthalmologist, PTOT, speech. Neuropsychology is also very difficult to get into in the state. It is the gold standard for cognitive testing. It is, but not everybody will need it if it's not maybe a complex case. Over time, maybe they're returning to work or to school and still having problems. That might be a good time to do it, but you're going to have to wait. If you can get into a speech pathologist who has extensive training in cognitive rehab, then you can get in quicker, and you will not have as broad. This is coming from a speech pathologist. The gold standard is the neuropsychologist on this. They're going to give you a lot of good information. Speech pathologists can also give you some good information that will speak to language and thinking, and what difficulties someone might have at school and work, and what accommodations might appear. So you kind of have to weigh out where you need someone to go, what their symptom is, where they need to go. The psychologist might be an option. So TEIS, Tennessee Early Intervention System, was under 3 years old. So once you hit your third birthday, then you had to go into the school district to get your continued services if you still needed them. Tennessee recently has an extended option, which now goes until the start of the school year following their 5th birthday. But you have to already be enrolled in early intervention services through the state, and then it can extend. So my understanding, how I read this, is that if you are injured at 4 years old, you're going to the school district as your first option. The extended really just applies to people who are already in services. And then after 5, you would go to the school system. They're probably already enrolled in school, get their services through the school system. So there's lots of support for symptom-specific referrals, a lot. So active in treatment, targeted treatments may enhance recovery after concussion, and we need to individualize that treatment. Again, lots of support. This is just some of it. And we love this. This is our infographic of the University of Pittsburgh Medical Center, or our slide. I'll show you their infographic on the 6 types of concussion. So after the first week, where symptoms are generalized, you may see symptoms break down into one or more of these categories. And that can be really helpful then to conceptualize the case and then think about, where do I want to refer? What's really going on here? I just want to point out the cervical. This is traumatic brain injury. So the way their injury occurred could have involved falling down the stairs, being in a car accident, just falling down to the ground for an elderly young person, not anybody, but sometimes more of an issue for the very young and very old. So it's the body has been shaken in some way, shape, or form. The neck can be out of place, and if it is, that can cause what appear to be concussion symptoms. So they may just have their neck is out and they're having symptoms, or it could be that they have a concussion and their neck is out. So if symptoms aren't going away, we often say, really check out that neck, because you fix the neck, you may see the symptoms go away altogether, or you might see them diminish. And now you know what you're really left with from the concussion itself. And then I like the fact that mood anxiety is now here, because I think we kind of, when we see someone coming in with persisting depression or anxiety, there's kind of this thought of, if you just get over that, you'd be better, you'd be okay. And sure, that can be a reaction to what happened, but it can also be primary symptomatology, depending on what part of the brain was impacted by the concussion. I think that's really interesting to think about, that we need to be dealing with that. So there are targeted and active treatments for all of these different areas, and exercise appears for all of them. So that's that low level exercise, getting back to some movement, probably increasing oxygen in the brain. They don't know, I don't believe exactly yet what the mechanism is, but exercise is a proven treatment for all of these areas. It's not coming up under ocular motor yet. I'll have to go back to the research. It might be there now, but I believe it will be there. I believe if you're helping the brain, you're helping all of these different symptoms. So I think it's likely to appear there as well. So on the really colorful, up and skinny infographic there is from the University of Pittsburgh Medical Center that goes through all of these. And we've created a fact sheet with it. With their permission, we use their infographic on one side, and then we give a summary on the next side. So reminding you that in the first week, the symptoms are going to be broad and generalized, and then reminding you about active treatment and what some of the risk factors are for prolonged recovery. So a note about the schools, they don't always provide all treatments that are needed. Services have to be academically necessary. All teachers and therapists don't understand brain injury. They don't know how to identify it necessarily. They don't know how to treat, and they don't know how to accommodate for it. That is a broad statement. That is not, there are some people who are excellent at it. It really depends on that teacher and on that clinician. But generally, I worked in the schools for about 2 years. And so I understood brain injury, but I also understood that most of my colleagues did not. They did not have a broad understanding, a good understanding of it. And the tendency then is to not pick up the child in the first place, or to really not know what to do in terms of treatment. So you reach one goal and don't be looking for the next goal that should be addressed and discharged at that point. So we again know that they're more likely to provide the service and support if it's recommended by healthcare. You also give the parents the I'm not going to say ammunition, but you give them what they need. You know, my doctor has recommended this. Even though the school doesn't have to follow that, you carry a lot of weight. Again, they don't have to follow it, but make it anyway, especially for like a neuropsychologist, if you feel it's necessary. And again, I'll stress that it's not necessary in every case. The more complex cases, yes, if someone's not improving, something's tricky here, we don't know what the real problem is, then we might need to dig underneath it and look for neuropsychology. I would even say in some behavior situations, sometimes the behavior is because of the cognition. It's because they're having difficulty and they cover it up with behavior, or they're so frustrated because they can't think fast enough, because you're pushing them when they're not quite there with you yet. So that might be a really good thought for a neuropsychologist there. And again, it helps the parents advocate. So this one's school-based. I'm going to show you work-based as well for the adults, but this is an accommodations tool that is good for you to come up with some accommodations, and you may have your own already as well. I love CBERT's Center for Brain Injury Research and Training, because on one side, they're just general things. How can we accommodate for an environment for transitioning between class to class, teacher to teacher? How can we change how we instruct them? What do we do with behavior and assistive technology? And on the other side, it's very deficit based. So, well, what if I know that there's a memory problem? What do I do? What can I try? I will sometimes give this to families if I'm working with them on an IEP, and say, circle the things that you think would be helpful. And generally, they will circle too many things. And I say too many because the school and even the student can't always focus on too many things. They need to really pick the things that they can target. They're going to make be the most successful for them. Focus on those, but know that all those other things are available that you can then try. You can try on your own. You can go back to the teacher and say, would you help me do this? So I love CBERTs. And for returning to work, the Job Accommodation Network, JAN, askjan.org, has great resources for return to work. They can also answer questions. Uh, Employers don't have an understanding of what reasonable accommodations are, and they have great lists and explanations. So they are by disability. So you can go in by aphasia, or you can go in by brain injury, or you can go in by your specific deficit. If you know that there's a speed of processing issue or a motor issue, you can go in and you can look for strategies that way. So this is a great resource to send your adult patients to, or students that are going back to work. Okay, so now we're switching to the yearly checkup. We've talked about that initial appointment. We've talked about that follow-up appointment, and now the yearly checkup. So we want to ask, well, over the last year, do you still have any residual symptoms? Have you seen any changes in school or work? Dropping in grades, difficulty with new learning, falling behind with work? Give them some examples. Any physical changes or challenges? Give them some examples there. Any behavior or mood changes? Any cognitive changes or challenges? For example, with your memory, with your attention? Do you forget your homework or your books at home? Do you have difficulty paying attention in your work environment where maybe there's lots of cubbies, people stopping by, people passing by, and you have a window there? Any start of substance use, abuse, any chronic pain, any relationship or friendship issues? Have you lost friendships and relationships over the last year? And any new injuries? And this is every year we're asking this, and refer out if needed. So why are we doing this? Well, that research that I showed you earlier that show that we have problems that show up years later. 1 year, there's a lot that we show up 1 year later. Things like learning disorder, and I won't read through all of these, but we see lots of problems that, again, don't show up necessarily for a year. I want to stress again, the bone, joint, or muscle problems, the way the injury happens, it can look like, I focused on the neck before, but if my neck is out, my neck might hurt today, and next week it's my shoulder. And then next week it's my lower back or my hip, because I'm compensating for an injury somewhere else, or misalignment somewhere else, and I may be creating a misalignment somewhere else. So it can look like, well, this child just wants to get out of school, or this adult, because now this hurts. They're trying to figure out what's going on, and we need to help them with that. And again, with academics, we may not see an issue for a full year, because we need time for that difficulty with new learning to catch up with them. So right away, they may look great. They're doing great in school. They went back, they're doing great. If new learning is their issue, then we're not going to see until that gap can widen over time. We need to be mindful, especially with adults, that adults are quick to explain away any new problem. So they'll say, yeah, I'm depressed, but there's a lot going on in my life that you can always point to something. So we need to recognize that it could be the injury. It could be. I'm not saying it is. Could be. And then they need to also trust the people around them, the people that love them the most. When they say they're different, encourage them to listen to that. So it could be a coworker. It could be a spouse. Could be a business partner. If they're telling you that you're different, or friends are dropping away, trust that, and look into that a little bit more. We know that the people who are seen in a trauma center, only about 44% are going to see a healthcare provider within the first 3 months. So again, need to check in. Even people with moderate to severe post-concussive symptoms, which were now, I believe over this last year, is now being called persisting symptoms. Even with 3 or more moderate to severe symptoms, only 52% saw a healthcare provider within 3 months. So those are the type of people that are out there that are really struggling and don't know what to do. So a large portion of people don't seek follow-up in their yearly visit, where they're just coming to you for a flu shot, or because they have to for work, for school, for sports. That yearly visit may be the first opportunity that anybody's going to get to catch these persisting symptoms and provide them with some help. So we need to be checking in. So children need to be monitored again because many things don't show up for a year. And even after that, even at 5 years, they show differences in difficulties in school, and they often require specialized assessments by neuropsychology and speech language pathology. So because, let's say, take that example of someone who was injured, never came to you, went to the ED, maybe never went to anybody, right? Because we still are fighting this idea that concussions just go away on their own. So now they're at you, they finally came to you 7 months later for their yearly checkup. We really highly recommend that you screen for prior history of brain injury for all patients. We love this one. It's OSU because it's modified to include acquired brain injury. So it's also going to look for, well, did you have, maybe there was a drug overdose or you had a brain infection over, maybe you just went to the hospital for it, a brain surgery, anything like that. It'll incorporate that as well. Another option is the HELPS, which also includes acquired brain injury, a little bit simpler, at least simpler looking. They're all pretty simple. There are different ages. You can go to nasha.org and find these tools. I'll also, if you want to email me, I'm happy to send them to you. And you cannot, as yet, get the OSU with the acquired. Trying to get that up there, but it's not there yet. You can also get that directly from me and take a look at all of them and decide what you want to do. If you won't do that, can't do that, I understand that there's a time pressure for sure. You can add some questions to your health history, like have you or has your child had a head injury over the last, since I've seen you? What was the cause of the injury? And if there was an injury, did you lose consciousness or become dazed? And an opportunity to write more. The problem with this is that you may have heard of Dr. Daniel Amen, who is very well versed in this area, and he's looking at scans of people's brains. So he knows when there's been an injury. He'll say, have you had an injury? And they'll say no. And he says sometimes he has to probe with 10 different questions to say, well, have you ever fallen? Have you ever done this? And sometimes it's that 8th, 9th, 10th question where they say, oh, do you mean when I was 2 and I fell out of the second story window? Yeah, we mean that. So sometimes it's not just concussion. Sometimes it's bigger injuries that are just, they're not thought about. So again, this might miss that. The deeper probes will be a little bit better at catching those things. So we have, like I said, a traumatic brain injury toolkit for healthcare providers. It has all of the resources that I've talked about so far and more. The ACRM has a tip card in there that you can give out. There's the Tennessee Return to Learn, Return to Play concussion management guidelines are in there. There is a free CDC training for 2 free CMEs. Great. It's a really good online training. You can get it at that link right there, tndisability.org/brain-toolkits. It also has all of those signs and symptoms, information on driving after brain injury, service coordination. There are 8 free service coordinators across the state of Tennessee that are there to help with more complex cases. If someone, maybe the person can't coordinate care on their own and they need someone to help them, they can even sometimes go to an appointment if it's warranted, and help also with the school. Tennessee TBI Services Directory is there as well. Just one caution, it's not always up to date. Sometimes people don't know to put their service in there, and the state may not know that they do brain injury services. There's a Resilience in the Brain fact sheet to help people understand how to become resilient, and that will actually change their brain. And there's a guide to possible changes after brain injury that's in there. That we developed that one because we realized that even when people had a more significant injury or a concussion and were treated, that problems develop down the line for them. So We put this together for people, hopefully on discharge from those services, to be given so that they can kind of look at it and go, oh, okay, if I'm having any of these other problems, I can come back and I can receive services. Here's where I might go. It has the specialties in there. One is 7 and under, and the other one covers school age and adult. And it's broken down into 4 sections with some supporting resources and references in there. The concussion management protocol is there, things to use in office, things that we recommend that you send home, and things that are optional, some other good things. And we tried not to overwhelm this. It is already a big toolkit, but we try not to there's so many things out there. We tried to really limit it to what we felt were the best things for you to be choosing from. And then obviously anything that you're already using that you like. There's also a new survivors, families, and caregivers toolkit. You can go into this and you can find something in one of those categories that they need, or you can just give them the link and tell them, hey, go ahead and look through this. So at this point, I'm kind of shifting gears a little bit. That's everything about the concussion management protocol and the Tennessee resources and the toolkits. And now I'm going to switch gears to a new program that we developed based on all of this communication with other groups and digging into the research and realizing that we are all connected through the research. These areas that are listed here, mental health, trauma, adult, ACEs, childhood experiences, adverse childhood experiences, sorry about that, child abuse, brain injury, homelessness, justice, domestic violence, chronic pain, substance use, and then several determinants of health like rural, minority health, realizing that the research is saying that we all overlap. If you have a brain injury, you are likely to have had ACEs, you are likely to have a mental health issue, to develop a substance abuse issue, to have chronic pain, to be involved in a domestic violence situation, either as the perpetrator or as the victim. So these are all related, and they are related to each other, even if you take brain injury out of it. So we developed Tennessee Brighter Futures. We meet every other month, and one of these groups speaks, and they have an opportunity to share with all of the other groups. And there are 70 groups and over 100 participants. Anybody is welcome. So if you want to be involved, I'll direct you first to our website I'll show you in a sec how to get there, and we'll be happy to send you an invitation to join. But from that, so you can go to our website, tndisability.org/brain, and then click on the Tennessee Brighter Futures button. That will take you to the website, and you will see there if you click on that kind of flowery looking logo that represents all of the systems, you'll find all of these circles with the systems of support listed. You click on the one that you're interested in, let's say it's substance use, and you'll see this page come up that has the information on, we've developed resource pages based on these. You'll also see here that there is the recorded meeting. You can download the PowerPoint from that meeting. You can download the resource page, which is that kind of in that bottom corner is a little thumbnail of the resource page. It'll give information about that topic, some broad information, intersectionality with brain injury, and then it'll go into the resources on that topic. And this is not for, let's say, if we're looking at substance abuse, not necessarily for the substance use provider, because they are very intimately knowledgeable about all of the pieces about substance abuse, but it's for folks, let's say, like me, who work in brain injury, yet someone comes through my door who has a substance use issue, and I say, okay, gosh, what do I do now? I can go to these, and they are telling me where I should be sending people and what tools are available, what educational handouts are available for me to give to them so that they can understand something more about it right now. There's also a text document if you need that for accessibility purposes. And there's a little thumbnail. So that's Tennessee Brighter Futures and how you can access it. I have all of the, there's a lot of, again, like I said, a lot of research that supports this concussion management protocol and the need for TBF. And this is all on our website as well, if you want this for any reason. And there's more than this, but I kind of gave you the most. So if you would like a certificate for attending this, you can take use your phone to capture that QR code and take our 1-minute survey. Once you're done with that, it will send you a certificate that you've attended this, if you can use that for any CME purposes or CE purposes. Thank you very much. If you have any questions, you can email me at wendy_e@tndisability.org. And thank you so much. Appreciate you being here.